Hello and welcome to today's webinar, Racism as the Diagnosis, Exploring Racism and Medical Trauma as Social Determinants of Health and Effective Strategies for Change, presented by Ms. Brittany Works. My name is Julia Hart, and I am a program coordinator with the Ohio State University's College of Social Work. I will be moderating our session today, and we'd like to start by thanking the Ohio Department of Mental Health and Addiction Services for generously sponsoring our Behavioral Health Workforce Development Training Series. Before we begin our session today, we do have a few housekeeping items that we would like to review. Ms. Works, if you wouldn't mind advancing one slide, please.
Absolutely.
Thank you so much. So firstly, please note that our session today runs until 12:15 p.m. We encourage your questions during our session today, but please be sure to put questions for our presenter in the Q&A box, not in the chat, to make sure that our presenter can see your questions. I did see a question in the chat about whether you're all automatically muted without video, and that is correct. So you all are muted and don't have video. So hopefully that helps answer any questions about that. But once again, please be sure to put your questions for our presenter in the Q&A box to help make sure that we can see your questions. And in the meantime, you're also welcome to use the chat to share reflections about the session, comments or relevant resources, or questions for other attendees. But again, please keep questions for our presenter in the Q&A. Today's session is eligible for 3 CE credits for social workers, counselors, prevention specialists, and chemical dependency counselors. However, please note that you must participate for the full training today in order to be eligible for credit. Unfortunately, we're not able to give any partial credit, so we do need a full attendance record in order to award credit. If you have not already provided us with your first and last name and your correct license number, if applicable, we may not be able to issue credit. Also, if you're calling in by phone from a different phone number than the one you registered with, if you could please email us at ohiopc@osu.edu, just so that we can match your phone number with your attendance record. And again, that's just if you're dialing in by phone from a different number than the one you provided us with at registration. Now, a knowledge check question will be given at the very end of today's session, and completion of that knowledge check is required to receive a certificate. And then an evaluation will be emailed out to you within 1 business day of today's session, and that evaluation is also required to receive a certificate. We send these evaluations from our Qualtrics survey software, so please be sure to check your junk or spam folder in the next day to check for the evaluation. And if you do not receive an evaluation by the end of the day tomorrow, and it's not in your junk folder, please let us know. If you've fulfilled all the requirements, including attending the full session today, answering the knowledge check at the end of today's session, and then responding to the evaluation that will go out within 1 business day, certificates themselves will be emailed to eligible participants within 30 days of today's session. Once again, so certificates go out to those who meet all the requirements, and those certificates go out within 30 days of today's date. So now that we have all of that covered, let's go ahead and get started. Our presenter this morning is Ms. Brittany Works. Brittany is the founder and executive director of Matters of Our Mind, LLC, and serves as a diversity and inclusivity anti-racism consultant for educators, nonprofit organizations, and community leaders to address structural racism, understand the impact of trauma in the workspace and community, and provide evidence-based models that promote racial healing and community empowerment. As a former prison therapist and supervisor for a community-based mental health team in metropolitan Atlanta, Ms. Works understands the impact of systemic racism and trauma. She believes that a balanced historical perspective coupled with evidence-based practices create individuals who are qualified to impact change. Ms. Works holds a Bachelor of Social Work from Oakwood University and a Master of Social Work from Clark Atlanta University. So at this time, I'd like to extend a very warm welcome to Ms. Works, and I will go ahead and turn over control to you to share your screen for our presentation. Thank you.
All right. Welcome. Thank you all so much for coming to the presentation this morning. I'm really excited about having this discussion about health disparities and health equity. So the racism as the diagnosis, as you know, exploring racism and medical trauma as social determinants of health and effective strategies for change. So just a little bit about me. She did read quite a bit. So I want to really discuss how I came to be an essential worker, or how I found myself in a hospital setting. My background has primarily been in mental health and in the correctional settings. I was a mental health counselor, and again, I worked in community mental health. But at one point, I decided to make a transition into medical social work, not knowing what I would find or get myself into. I had never had any real medical experience in the past. And so working in the Atlanta area, the hospital that I initially started working for was a more affluent hospital in a white affluent community in a metro area. And working there, the thing that struck out to me the most was I really got a picture of how insurance companies worked and how complicated insurance could be. But rarely did I come in contact with people who had discharge barriers or who were unable to access healthcare necessities due to income or other social barriers. If I had a patient come to the hospital, with more than likely they had the resources to discharge home safely. But I did transition. I transferred to a different hospital that was in the Atlanta area. And this hospital was a predominantly African-American community population, predominantly lower income. And the differences that I saw in healthcare were astronomical. And that's kind of what led me to this discussion on healthcare inequity. So as we get into our presentation, I want to go over our learning objectives. There are 4. First, we are going to identify at least 3 historical factors that contribute to the medical trauma and mistrust of the healthcare system in the African-American community. Number 2, we are going to discuss the impact of medical trauma on health behaviors and perceptions in African-American communities. 3, we're going to review the present day impact of racism on health in African-American communities. And lastly, number 4, we are going to explore effective strategies to address medical trauma and mistrust of the healthcare system. So before we really get into our presentation, I would love for us to do a little icebreaker. So I believe Julia's going to pull up a poll. Is that right, Julia?
Yes, I'm pulling up the poll right now.
Thank you.
Sure. So for anyone joining by computer, you should be able to respond to the poll on Zoom. If you do not see it come up, you may need to make sure it's not hidden behind another window. And you may need to click on the bar graph icon on the bottom Zoom toolbar that says polls. Occasionally, you may also need to click on the ... button that says more to pull up the poll area. And for those joining by phone, just so that you're aware, our poll question that we're answering right now is, I'm attending this workshop because, so A, you work in healthcare and want to better understand the issue of health disparities so that you can be part of the solution. You're not in healthcare, but you're still interested in the topic, or maybe you just need some CE credits. So we are giving everyone a chance to answer this question now. And if you're not able to respond within the poll, please feel free to respond in chat if you feel comfortable doing so. It looks like we have over 90% of responses in, so thank you very much. If you've not had a chance to respond yet, please feel free to do so in the chat. And I'm going to go ahead and end the poll now and share results here.
Are you able to share or do I need to share it?
It should be sharing now. Are you seeing them on your screen?
I see it on my screen. Okay, so it looks like the question is, I'm attending this workshop because most people say I work in healthcare and want to better understand the issue of health disparity so that I can be a part of the solution. Coming in second is I'm not in healthcare, but I'm interested in the topic. And we have a third say, I need some CEUs. So I understand that. So my goal is that after today's presentation, everyone will gain a better understanding of healthcare disparities, not just understanding where we are, but how we got there. All right, so let's get into it. So as we go into our presentation, I want you to be self-reflective. I want you to think about your perspective as it comes to healthcare, maybe some of the beliefs that you hold as a practitioner, as an everyday citizen, and how some of those perspectives may either contribute or help the issue of healthcare disparities. I also want you to be thinking systemically. As we go throughout the presentation, we will discuss how systems and government have a crucial role in the healthcare disparities that we see today. And lastly, I really want you to think collectively. The healthcare disparities that we are seeing today are not a experience of just one person, but a collective community. Communities are experiencing this together as a whole. So it's not just one individual, but again, it's a collective group process and experience. So you may want to ask yourself a few questions like, as we learn new things, how do these events impact African Americans as a collective group? So Martin Luther King once said, of all the forms of inequality, injustice in health is the most shocking and the most humane. Again, starting off my career, my medical social work career in an affluent hospital area, and then going to one in the inner city, seeing the social barriers that impact people's health and the difficulties in just having access to appropriate health care is really mind-boggling if you're able to experience it firsthand. And I don't think that I would have ever thought that the highest form of inequality was in healthcare prior to that experience. So why are we here? So what happened is in 2019, 2020, the coronavirus hit us and it shook the world. It really changed the dynamics of how we have lived our life since that time. But also occurring at that same time was a social justice movement almost directly connected to the death of George Floyd. When George Floyd was murdered so heinously, it opened up conversations in the workplace and in different spaces that we weren't really having them before. So there may have been some conversation about race prior to the death of George Floyd, but after he passed away, after that incident that really changed the world, spaces like our work environment started to have conversations. So you had this social justice movement taking place on top of the fact that we had this coronavirus that was disproportionately impacting people of color, especially African Americans. We ended up seeing just how bad these health inequities were. And at the same time, people were open to conversations about it. So the undeniable effects of racism have led to unacceptable health disparities that especially hurt African Americans, Hispanics, Native Americans during this pandemic. And what we know is that very few of these comorbidities have racial determinants. Almost all relate to the social determinants of health, dating back to disadvantageous conditions that some people of color find themselves in from birth regarding the availability of an adequate diet, access to health care, and undeniable effects of racism in our society. So we know that the health inequities exist. The next question is, how did we get here? How is it that we are in this place where we have such large gaps in healthcare between Black and white counterparts? The one question that we have to ask ourselves is, why do the barriers exist? Why do the barriers exist? And then how did the barriers come to be? And I think it is vital whenever we're talking about, quite frankly, any issue dealing with trauma in the African American community, it is essential to look at the historical perspective. It's very easy to look at the surface and the symptoms of the racism. The symptoms would be the healthcare disparities, but understanding how we got to this exact point so that we do not continue to repeat history is essential. Much of the information that I'll be sharing is inspired and comes from the book Medical Apartheid, which was written by Harriet Washington. She says, trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting at their own medical history. You're doomed for failure. We cannot understand such a deeply rooted systemic issue such as disparities in health without understanding how these things came to be. When we fail to do this, we are simply not treating the whole problem. We're treating a small symptom. So as we get into the impact of racism and historical trauma on healthcare disparities, I do want you to know that you may be learning some new things, and some of these new things may be difficult to digest. We'll have moments where we can kind of pause, take a break, and just really process some of the information. Before we get into this section, I would like to know, are there any questions at this point, Julia, that may need to be addressed?
I have not seen any content questions at the moment. A couple of folks were saying that they were hearing some feedback from the mic. Most people are saying that they are not. A few people are saying they are. I think I could hear maybe like a slight bit of background noise, but it's very minor.
I did. Unfortunately, today the community landscaper is out, and I did not know that would be happening. So it sounds like he's on the other side. Hopefully we won't have much distraction from that. So are you guys able to hear me well now?
I'm hearing you fine, and many people are telling me they are as well. So I think for those who are having any issues with the audio, it may just be that slight background noise. Just as a quick reminder, we do have closed captioning available if you're having trouble hearing. So that's an option that you can use if you're having any trouble with the audio. And also a few people said that the slides were a little blurry. The slides themselves, as far as I'm seeing, there's not an issue. I believe occasionally if you're having a connectivity issue, the slides may look a little blurry if your bandwidth is a bit lower or if you're having any sort of disruption to your internet. So if you're having trouble, let me know. I can send you, there's a troubleshooting page from Zoom about what to do if you have connection issues. But I think, oh, and someone else said, that headphones can I think maybe wearing headphones may help if you're having audio issues. So
so what I'll try to do is make the slides a little bit bigger because some people are saying that it's blurry. I'm hoping that will kind of help the issue.
We also have a copy of the slides, which I've been sending out, so I'll send that again so that if you, that should make it less blurry. Thank you.
All right. So let's jump in. Now, this is I want you all to participate and feel comfortable jumping in the chat box, asking questions throughout the presentation, as well as giving comments, because I'm trying to be in the chat box as much as possible. I love engagement. So I want you all to answer this question. When we're looking at the root of healthcare disparities in this country, if you can name one word, identify one word, what is the root cause to healthcare disparities in this country? I actually showed the slide a little bit ahead of time. Elaine says money. Emily says money. Finances, absolutely. You all hit it right on the nail. The root of healthcare disparities in this country is economics, okay? So when we go back and we look at the relationship between the slave owner and the physician, what we will find is that they had a mutually beneficial relationship. They were both able to benefit from each other financially. As a slave owner, whenever you were investing, because remember, African Americans at this time were seen as 3/5 of a human. So one slave did not equate to a whole human, only 3/5 of a human. So as slave owners, slaves were property. if you're making an investment in your property, you want to make sure that you're making a good investment. And you want to make sure that you have a healthy slave, someone who can, you know, stay alive and stay well to work for you. So most often, whenever a slave owner or a planter was going to an auction to buy or sell slaves, they would have a physician with them. Why? Because the physician served as, you know, they were the doctor who was able to assess the slave to see if this was a good investment or not. So they helped to protect the they helped to protect the investment, and they also treated the slaves. And whenever a slave was sick, this allowed for the physician to have a consistent workflow, because slaves did become sick often due to being malnourished and poor treatment. Also, medical experimentation. Medical experimentation was a benefit of the physician because slaves had so little value that their treating a slave was an opportunity for medical experimentation and to grow your knowledge of the medical field. All right, so when you're looking at the medical treatment of slaves, the South wasn't a particularly unhealthy place. So the common forms of treatment was induced vomiting, experimentation, delayed treatment. This was the what I would say the common experience of a slave. The South being a particularly unhealthy place, it housed 90% of slaves, many of whom were malnourished. It combined the pathogens of Africa, Europe, and North America. Infectious disease such as hookworm, malaria, yellow fever, diarrhea, they were very much commonplace. And induced vomiting was an everyday event because during this time, it was largely believed that violently releasing bodily fluids was how you treated or healed disease. And these practices, which were awful, often resulted in copious bleeding, blistering, and violent diarrhea. This was standard practice. So you can imagine just how awful an experience it would be to go to the doctor. So harsh laxatives were used that created bed sores. There were no antibiotics for these bed sores. There was common heart failure, gangrene, nervous system failures because of mercury. This was just the common experience. So it was an atrocious experience to be had. So when we want to talk about the slaves' access to healthcare, although planters and slave owners depended on physicians to treat their slaves, it was not their first go-to because it cost money. And the first step being seen by a physician was a last resort. Also, most slaves, because of these terrible experience, they preferred to be treated by the slaves on the plantation who could that would use more natural remedies to help with their illnesses. So this was, again, just as a general experience of Black people during this time, going to the doctor was not something that was a pleasurable experience, and it was often coupled with trauma. I see that there's a question. Julie, could you catch that question for me?
Yes, sorry about that.
No problem.
So I see the question here just says, do you think this caused not only the suspicion of the medical profession, but maybe also the rise of maybe some folk and traditional medicine in the African-American community? And the participant said, my family's from the South and they still use non-traditional medications first before going to any doctors.
Absolutely. Yes, well, that's true. I think that does contribute, but even prior to being colonization and coming to America as slaves, it was very common practice for Africans to use herbal medicines for treatment. So I think as a part of our tradition and culture, coupled with the experiences we had with doctors during this time. Let's see, where are we? All right. So another trend occurring during this time in the medical field is the rise of scientific racism. Again, the focus of scientific racism was economics. Scientific racism is the spread of bogus theories of supposed Black inferiority in an attempt to rationalize slavery and centuries of social and economic domination and plunder. So in order to justify the horror of chattel slavery, the humanizing characteristics were attributed to African Americans. So we're going to look at what some of those characteristics were. Phrenology. Phrenology is a pseudoscience which involves the measurement of bumps on the skull to predict character and mental ability. Now it's interesting because I remember hearing several times throughout social studies in high school about phrenology and how it was a pseudoscience, but never did it state that that phrenology was specifically used to dehumanize African Americans and to attribute negative characteristics to us. Also during this time was drapetomania. This was a supposed mental illness described by the American physician Samuel L.A. Cartwright in 1851. He states that this particular disease caused Black slaves to flee captivity. So if a slave had drapetomania, that means that they had a disease that caused them to want to run away. So today, drapetomania is obviously considered an example of pseudoscience and a part of the edifice of racism, of scientific racism. Another aspect of scientific racism, again, all of these things were used to simply justify slavery, and the reason slavery needed to be justified is for economic gain, was African Americans don't feel pain. Now, this is something that is deeply critical because even today, studies are showing that physicians and medical students believe that African Americans have a higher tolerance for pain than our white counterparts. African American children are prescribed less pain medication after receiving a broken bone. And even speaking of bones, you hear there is a stereotype that African Americans have bigger bones, big bone. These are all things that were utilized to continue slavery. Another idea was African Americans were better equipped to stand the rays of the sun due to an eye feature found in apes. Now, this is so ironic because I see this idea of African Americans having better skin for the sun. A lot of African Americans do not use sunscreen because they believe that their skin is stronger and better equipped to stand the rays of the sun, and it's absolutely not true. I have to even say for my own self, I was raised to believe that we didn't need sunscreen. And it wasn't until I took a trip overseas thinking that I didn't need sunscreen and I was terribly sunburned that I realized, okay, this is foolishness. And that was only but 3 or 4 years ago. So it's so easy for some of these ideas and beliefs that we have to continue and to stick with us throughout generations. Thomas Jefferson said, in imagination, they are dull and tasteless. This unfortunate difference of color and perhaps of faculty is a powerful obstacle to the emancipation of these people. So Thomas Jefferson, former president, he says they're not very smart, their brains don't work very well, and they are uncivilized. I don't think that they are equipped to be free. Again, another reason to justify our enslavement. Okay. So we want to look at, and this is very important, pay attention to this, policy's impact on the Black body. In 1807, there was the act of the federal government passed the act prohibiting the importation of slaves. This meant that international slave trade was prohibited, right? That sounds like we are heading in a good direction, right? Toward abolition. They stopped the international importation of slaves. However, this act did something, and this is where I want you to think and participate. While it stopped the international slave trade, it still allowed for domestic slave trade. So internationally, we cannot trade slaves, but domestically we could. What is going to be a consequence of this action? I want you to get in the chat. I want to hear your comments. Why would the federal government pass a law that would prohibit the international trade of slaves, but continue to allow domestic slave trade?
So I see in the comments, someone said maybe war.
Somebody said war.
Someone said economics. And then breeding to the humans to produce more slaves.
Breeding humans. They're coming in quickly. Okay.
Yes. Keep the money in the US versus international.
Absolutely. It's right there. It's all about the money. Okay. The benefit is simple. Once they stopped international slave trade, they were allowed to trade domestically, which increased the price of the slave. What does that do to, how does that directly impact the slave's body? We had slave breeding at that point. That's when we began to breed slaves in this country. As of 1808, when Congress ended the nation's participation in the international slave trade, planters could no longer import additional slaves from Africa or the West Indies. The only practical way of increasing the number of slave laborers was through new births. With so much at stake, Black women's reproductive role became politically as well as economically decisive. If enslaved mothers did not bear sufficient numbers of children to take the place of aged and dying workers, the South could not continue a slave society. Okay, and that comes from birthing a nation. So that at this point, African-American women are on plantations breeding slaves. So they would take a 12, 13, maybe a 14-year-old. 14 would probably be a little older, but really probably around 12 years old. Take her to a breeding farm where she would begin to breed children. And she was required to birth at least 15 children, as many children as possible. After birthing 15 children, she would then be able to be free.
And I see a question, like a clarifying question in the chat. So someone said, so essentially they were just creating a higher demand for humans.
Right. They were, what they were, well, the demand was there, right? But instead of paying less money, because it was cheaper, you know, getting anything overseas is going to be a little bit cheaper. They stopped that so that they could just simply make more money off of the slaves in this country. And in order, but they needed slaves. So they just rapidly produced them so that they could have the slaves to trade and to work within the US. Does that clarify the question?
Yeah, yes, they said it does. And then someone else asked, free as in their personal freedom. I think they mean for the girls who, you know, if they gave birth in that time.
If you gave birth to 15 children, you were allowed to be free, meaning you no longer a slave. But okay, just imagine the trauma connected to giving birth to 15 children that you never get to raise and nurture, and then to call me free after I've given birth to 15 children that I don't get to raise.
Absolutely. Thank you.
There's a lot of different traumas within this, just this example of slavery. Thomas Jefferson, because again, this is economics. I know no error more consuming to an estate than that of stacking farms with men almost exclusively. I consider a woman who brings a child every 2 years as more profitable than the best man of the farm. What she produces is an addition to the capital, while his labor disappears in mere consumption. Listen, this is all about the money. He's saying it's crazy for you guys to put a bunch of strong men on your plantation. You need to put women who can bear children, because while these men are going to get older and eventually they're going to get weaker and their value will go down, these women can give you a new child at least every 2 years. So she's adding to your value. So this is the perspective, and this is the value that Black women had during this time. Oops, where we at? Give me 1 second, I lost my place. Where we go? Here we go. All right, so I'm gonna look at Mr. Marion Sims, Dr. Marion Sims. Dr. James Marion Sims was an American physician in the field of surgery, both known as the father of modern gynecology and as a controversial figure for the ethical questions raised in developing his techniques. How many people are familiar with Dr. Marion Thomas? You can just in the comments, I'm curious. So I see a few people were saying that they're familiar with him. So first, we want to look at this false narrative, and narrative is very important. And when we're talking about trauma, historical trauma, and medical trauma, narrative. Look at this picture. This picture right here, it always amazes me. You have Dr. Marion Sims, you have some of his assistants, and you have a slave woman who's on the table. Now, he performed 30 operations at least on slave women without the use of any medication. Why? Because again, they say that Black people don't feel pain. So in this picture, you see her lying here almost submissively, like she knows what's getting ready to happen, when in reality, this is a very false narrative. Dr. Marion Sims and his crew would have to fight teeth and nail with these women to get them to lie down on this bed for medical experimentation because it was excruciatingly painful. But the history is going to paint the picture in this way. This was a bloody, gory scene. And whenever I get the opportunity to tell somebody what this picture really is supposed to look like, I take that opportunity, because too often in African-American communities and in the communities of other people of color, where we have these false narratives being pushed, and they're even the language we use, as well as even the images that we use, need to depict a real experience. So, you know, he experiments on all of these women without the use of medical experimentation, without the use of any medication. What I always find so fascinating about this is how Dr. Sims, knowing that he had to fight these women to be still, that he had to hold them down, that he needed his co-workers and colleagues to keep them still, that he could say African Americans don't experience pain. Oh, they don't feel pain. He heard the screams, he heard everything that would go into a surgery without medication. He saw and heard it, yet he contended that African Americans don't experience pain. That, my friends, is what we call cognitive dissonance. And oftentimes we have to justify when something just does not sit well within our conscience, we have to justify it to make us feel better. It's a part of the human experience. When something does not bring us peace, we either change it, we change the behavior, or we justify the behavior to make it make sense. And this is a perfect example of what has traditionally happened throughout history when it comes to many people in the white community, where the pains and the experiences of African Americans are completely ignored because it is inconvenient to face that truth.
And we did have a question, Ms. Works, if you don't mind. Someone was asking, what time period was this when Dr. Sims was experimenting?
Dr. Sims, let me Google that really quickly. 18. Is it 18? I should know that. I'll get that for you in just a moment.
Okay, thank you.
All right, let's go. I will answer that for you in just a moment. So we want to look at the next slide. Okay, so this is more than Tuskegee. So there are other notable examples of medical experimentation in the African-American community. Oftentimes, whenever we talk about medical experimentation, the first thing we say is we talk about the Tuskegee syphilis experiment, where African-American men were given syphilis, and it was allowed to just spread so that they could just kind of see what course it would take. And this was not that long ago. This was happening, this experiment was from the 1950s, 1960s, and 70s. So this was a relatively recent project. But there are so many other examples of medical experimentation that occurred in the African-American community that I think are essential to understanding healthcare disparities today. So who's familiar with the Resurrection Man? Resurrection Man Basically, these were body snatchers in the state. During this time, again, this was a great time for medical advancement, and medical students needed bodies that they could experiment with. So right here, this is taken from Indiana Historical Bureau at Indiana State University. This is a newspaper. Gang of body snatchers arrested in Indianapolis. Prominent doctor implicated, have stolen over 100 bodies. While it was illegal, the practice of stealing corpses to sell to medical schools often went unprosecuted, as it was perceived as being for the greater good. The dissection of cadavers, whether obtained legally or otherwise, has been used to train new physicians in anatomy, leading them an unprecedented level of understanding the human body. This, along with the fact that most of the victims were people of color, also helped law enforcement turn a blind eye. However, as the practice continued and more prominent families became victims of this traumatizing act, more laws went into play to end this practice. So they would just go snatch a body. You know, imagine burying your loved one and you go and visit their grave, and just a few days later, that body is gone and being used for medical experimentation. And there are a plethora of universities that have participated in body snatching. That includes the Medical College of Georgia, Medical College of Virginia, Harvard Medical School, and some of these more prominent colleges like Harvard, they've apologized for these acts. Johns Hopkins University, the University of Virginia, Yale Medical School, Medical College of Ohio and Cincinnati, to just name a few. So Ed Cade, and this is not an actual picture of Ed Cade. Ed Cade, he got in a car accident on March 24th in 1945 and fractured bones in his arms and legs. While waiting for treatment on April 10th, he received injections of 5 milligrams of plutonium without his consent. He did not receive any treatment for his bone fractures until 5 days later. 15 of his teeth were extracted to see the results of the radiation, and he died 8 years later from heart failure. Another major part of the medical trauma and mistrust that African Americans have in our current medical system has to do with a lack of consent. So oftentimes African Americans were given little or no consent to certain experimentations that occurred. How many people are familiar with Henrietta Lacks? I believe there's a Lifetime movie about, or there's at least a movie coming out, or it may already be out. Henrietta Lacks, a 31-year-old African-American mother of 5 from Virginia. She died of cervical cancer. Medical researchers used her cancer cells. They took her cancer cells without her permission, known as the HeLa cell line. Lacks cells are one of the most vital cell lines in medical research. It has been used to study the effects of toxins, drugs, hormones, and viruses on the growth of cancer cells without needing to experiment on humans. The HeLa cells were used to develop the polio vaccine and in cancer and AIDS research. So they aid in both cancer and AIDS research. Doctors never, to this day, have gotten permission from Lack's family to use her cell line. That's so intrusive. It's so intrusive. And again, without her permission. So while they're creating a movie for her in her honor, the permission, they still are using her cell line without the permission from her or her family. Fannie Lou Hamer and the Mississippi appendectomy. She actually became a powerful source in the civil rights movement. In 1961, when she was 44 years old, Fannie Lou Hamer went to the hospital for the removal of a small uterine tumor, which is now thought to have been probably a fibroid. While she was under anesthesia, she was given a hysterectomy without her knowledge or consent. This medical practice was known as the Mississippi appendectomy. Oftentimes, many women went in believing they were going to have a specific surgery for a persistent medical concern, such as lower abdomen pain, but experienced forced sterilization while under anesthesia. teaching hospitals frequently perform these unnecessary hysterectomies on poor Black women as practice for medical students. Before 1960, there were approximately 70,000 forced sterilizations that occurred in the United States. A large percentage of these victims were either people with cognitive abilities or poor women of color. According to research, 60% of the Black women in Sunflower County, Mississippi, during this specific time received such forced sterilization. 60% were victims of the Mississippi appendectomy. So those are just some, scratching the surface of some of the examples of medical experimentation and just mistrust that African Americans have experienced throughout history. So I see that there are a few questions. I'm going to kind of go to the chat box. Julie, if you can help me with those questions.
Sure. So going back to the one about the time period, I did a really quick search online, and it looks like a couple other people found this too, that Dr. Sims, so he lived from, I put it in the chat, I think it was about 1818 to 18, I have to double check those dates, but it was 1800s, and the majority of the experiments were 1845 to 1849 for the person who was asking about the time period.
Absolutely.
And then going back to what we were discussing earlier about pain tolerance, someone asked, do we know if this concept or myth about pain tolerance of African Americans is taught in medical school?
It has been taught in medical school, and just recently, and now let me see if I can find that on one of our breaks. I'll see if I can pull up that article where I believe they had to, no, I think what was said, I don't think it was that we had higher pain tolerance, but what has been taught is that we will often request lots of pain medication. I'm gonna clarify that, but I believe that probably at one time it was taught, and it continues to resonate with medical schools because they continue to prescribe lower amounts of pain medication to African Americans versus their white counterparts who have the same medical experience. So I want to kind of check in, and what are people, well, I'm sorry, Julie, are there other questions?
Yeah, so one question was, I think they were talking about like the Tuskegee experiments and the other items we were just mentioning. Someone asked, do you think this highlights that physicians have historically not been held accountable for some of the human atrocities?
Absolutely, they have not. Absolutely, they have not been held accountable. And even if you look at the book, A Medical Apartheid, she talks about, doctors during that time, and even to some degree today, they are considered to be the cream of the crop of our society. So when she was doing her medical research to create the book, there were so many things that were in the medical journals that she said were just atrocious and racist, just were flat out racist. But because nobody was checking medical journals and nobody was really qualified to go behind doctors to state this is incorrect, it just went relatively unchecked. And then also, I think a lot of it is bias. A lot of it is bias that's why I said at the very beginning of the slide, I want you to be examining what it is that you believe, because oftentimes we contribute to these ideas and don't even realize it. And so when you have a bias, you carry it with you, even when you're prescribing medication, when you're doing your discharge plan, when you're deciding what level of regard to give to a particular client. Oftentimes those long-term bias are there even without us knowing.
Absolutely. And another kind of similar question someone asked, are the medical procedures that were done with or still done without permission part of the biggest contributors to generational mistrust between African Americans and medical professionals?
I think it's a collection of things. I think, and we'll get more into it in our second part, a lot of it has to do with what happens when we come back and tell those stories to each other. Like when I have a negative experience at the doctor and I come back home and I share that experience, that experience that I share is going to have a major impact on how other people in my family and community encounter or perceive treatment. And then also, yes, those direct medical experimentations. And again, scratching the surface. This is just scratching the surface. We could do a 3-hour presentation on just the experiments themselves. Absolutely, we don't forget those. Our stories, again, that narrative is never out there. Those stories, like when I would often think about the slaves that Dr. Marion Sims would experiment on, when they had to go back to their slave houses and when they went back to where they lived amongst other slaves, what did they share? What was the experience like to say, this is what happened to me today? This is what I felt today. For those slaves who had to watch and stand by, just the trauma of knowing what occurred. All of those things are contributing to how you feel about health and how you're going to want to engage a healthcare provider. And very few of our stories are out there, unfortunately. All right, so we check in. I asked you guys how you felt. What's going on? Like, what are you thinking? Are you okay? Was this a lot? Was this what you were expecting? I see anger, yeah. Absolutely. So I see a lot of anger, sadness. That is the experience. All right, so what I would like for us to do is we're going to go into section 2, and we're going to stop around 10:30 for a little break. But going into section 2, we are looking at racism's current impact on African American health outcomes. We're going to look at the Black body. We are going to look at the poor health outcomes and cultural identity, as well as our general mistrust of the healthcare system. So let's get into it. And Julie, if at any point there are questions, were there any more? Because I just kind of went going.
This one wasn't so much a question, but someone was saying part of this past history of medical treatment is why African Americans are maybe reluctant for the COVID vaccine, which if I recall, you will be discussing in more depth later.
Absolutely. We sure will.
Okay. And then someone also, I was asking if you've read or heard of a book, The Mismeasurement of Man. It's about psychological testing.
Well, that sounds good. Let me write that down.
Yeah, they said it's about how psychological testing contributes to delusions of race differences. So.
Oh yeah, I bet that's good. Thank you for that resource. I love receiving resources. Okay, so we're going to look at racism's current impact on African American health outcomes. This section is broken down into 3: the Black body, cultural outcomes, and identity, and mistrust of the healthcare system. All right, let's go. We're going to look at chronic stress and its impact on Black health. So in order to really understand the impact of chronic stress on the African American community, we are going to watch a video on epigenetics. And epigenetics, if you don't know, epigenetics is the science of understanding how environmental factors change or mark our DNA and how that can be passed on through.
And some of those.
All right. I would love to hear your feedback. And Julie, maybe you can help me with some of the comments. I saw that some did come in. Maybe there are some questions. I love, love, love this video because it uses the example of how trauma can really impact our DNA and how it can be, we can pass that onto our children. Another example of epigenetics, there was a study with mice, and they did a laboratory study with mice where they conditioned them to be afraid of the smell of cherry blossom. They would expose the mice to the smell of cherry blossom, and then they would immediately shock them. So eventually the mice would just have a fear of cherry blossom without it being connected to any actual shock. And when those mice had children, those baby mice or the next generation of mice, they exposed those mice to the cherry blossom smell, and they would shriek at the smell because that marker in their parents' DNA. So even though they had never experienced the shock, they still had the same reaction to the smell of cherry blossom because that trauma or that genetic marker had been passed down. So yes, Julie, if you could help me, I see some coming and I want to hear all of the comments. They're coming pretty quickly.
Yeah, they are. So I saw one person was saying that they've heard there's some research that suggests environmental or life stress can actually affect at least 3 generations. If a
Absolutely.
woman experiences significant trauma, her eggs are affected. And if she has a daughter, that daughter's eggs are developed at the same time as everything else in utero. So 3 generations can be affected at
And
once.
at the same time, absolutely. So, I
Yeah.
mean, it's really fascinating, but when you think about the way that the body is made and how females, you know, we carry those eggs at conception. At the time that my grandmother was pregnant, my grandmother was also carrying me. You know, once she was pregnant with my mother, she was also carrying my egg, and all of those genetic impact, all of those genetic factors, all of the things that contributed to her stress was also contributing to my mother's stress, and also, I believe, mine at that time. And I think that's just how it works universally. And I believe that if you have exuberant amounts of trauma, such as the Holocaust and the Pan-African, the slave trade, those all contribute to genetic markers that are passed down. So when we really stop to think about the experiences of African Americans just from the slave trade, and you look at our place in history, and many of the comments that I saw, many people were saying, well, I've never heard this before. There's so much to our history. There's so much horror to the history of African Americans in this country. All of it, while the stories may not be known, they all contribute to our bodies and our genetics and what we pass down to our children.
Absolutely. I also see some people saying they're surprised that more people don't believe or put more stock in epigenetics. Someone said that one population they didn't mention in that video was Indigenous peoples. And then also just something that so many people do not think about, how trauma can be a health crisis.
Absolutely. And we'll get more into that. So I wanted to, as we start looking at the African American body, we are, well, I lost my train of thought. As we begin, I want us to go in understanding how epigenetics works and the things that have been passed on from generation to generation. So we want to look at collective memory. Remember in the beginning, I told you there were 3 things I wanted you guys to do: be self-reflective, think about structural, think structurally, but also to think collectively. So collective memory refers to how groups remember their past. So how will trauma impact the way we remember events from past as a collective? These memories and experiences are passed down, even if they are not your experience. The experience, even if it's not your direct experience, that experience can still be passed down to you, and it becomes a part of your trauma memory, and it also impacts your perception and how you engage. Now, in this particular example, we're talking about healthcare, but it could be anything. So I know, for example, I was raised by my grandmother. So I was raised by a woman who today is 78 years old. So I always had somewhat of an old soul, but there were certain things that my grandmother would always say that I thought were so strange. There were just a few things like, what is she talking about? That doesn't make any sense. Every time we had to take her to the doctor, she has chronic pain because of her back. I don't want these folks experimenting on me. That is just how it would come out. And I grew up hearing that as just like a normal, everyday part of conversation. It wasn't until I became older that I really began to understand that my grandmother, that experience that she had, or that fear, was directly related to the experience of her ancestors and what they'd experienced through the medical system, and what she may have experienced as well. But those stories of trauma, for example, when I think her name was Anarcha, that was the name of the slave that was most experimented on by Dr. Marion Sims. When she came back to her slave cabin, the stories that she told became a part of everyone's collective memory. So while other people in that same slave cabin did not have the exact experience she had, because of her stories and because of what they heard and the secondary trauma, it became a part of their experience and how they would engage and perceive healthcare. And the same thing happens today. So I don't think I've ever personally been like super suspicious of healthcare, but well, I've always kind of had one eye open when I've been with my doctors, because it's like, okay, can I trust you? I've always, okay, I need to know that I can trust you. And a lot of that comes from just listening to my grandmother speak about her everyday experiences. So when we look at chronic stress is chronic stress is a long-term form of stress that derives from unending feelings of despair, hopelessness as a result of factors such as poverty, family dysfunction, feelings of helplessness, and or traumatic early childhood experience. So stress is a physiological demand placed on the body when one must adapt, cope, or adjust. And chronic stress associated with health disparities includes perceived discrimination, neighborhood stress, daily stress, family stress, just accumulation of stress, environmental stress, maternal stress. All of these factors are weighing the body down, whether we recognize it or not. And if you grow up in lower income communities, if you grow up in communities that have racial trauma or historical trauma, it is common that you will experience chronic stress. And in these same communities, you will see that they represent more chronic, like higher comorbidities in these communities. You know, whenever I'm discharge planning with some of my patients, they just have barriers that we wouldn't think about. So it's like, okay, we're discharging you home. Well, I don't have anywhere to live. Well, we need to give you medication. Well, I can't afford it. Well, okay, we're going to pay for your medication. Go pick it up here. I don't have transportation. It's every step of the way there is a barrier, and that weighs your body down and impacts the way you're able to respond to stress. So if we look at long-term activation of the stress response system and the overexposure to cortisol and other stress hormones that follow can disrupt almost all of your body's processes. So some social factors and health risks that affect African Americans that contribute to chronic stress is higher unemployment, living in poverty, lack of home ownership, lack of access to health care, smoking, less physically active, and higher levels of obesity. All of that contributes to chronic stress. And so there are also diseases that are contributed to chronic stress. You have your cardiovascular dysfunctions, heart disease, diabetes, which is greatly and largely connected to heart disease. You have cancer, autoimmune syndromes, mental illness such as depression and anxiety disorders, all oftentimes caused or triggered directly by chronic stress. And oftentimes when we talk about things such as diabetes, we know that stress is a contributing factor, but rarely do we see stress as the primary factor to some of those diseases. Bear with me, I'm trying to navigate multiple screens. Okay, so here we see African Americans are more likely to die at early ages of all causes: high blood pressure, diabetes, and stroke. And we'll get more into diabetes later in really just a few moments. So when we're looking at some of the health disparities, some of the statistics, we're more than double the infant mortality rate. And someone mentioned earlier in the chat, I can't remember who stated, but they were saying that maybe some of this traumatic history contributes to the infant mortality rate, the differences between Black and white and infant mortality rates. Absolutely. There is a documentary, if you all get the opportunity to watch it, it's called, I believe, When the Bow Breaks. Ooh, I got to get the name of that. But it talks about health inequities, but it speaks specifically to the infant mortality rate. And what they stated was so fascinating to me, because the infant mortality rate amongst Black and white was so different. It was double the rate for African Americans, that scientists and researchers began to think, okay, maybe African Americans have something within them genetically that causes them to have these deficits with infant mortality. So what they did is they said, well, let's just do some more research. They went to West Africa, where the majority of Black slaves are taken, and they studied West African women and their mortality rates. And they found that the women of West Africa had the same infant mortality rates as white women in America. So they're like, okay. Then they decided to study the first generation of African immigrants. So if you come to this country and you have a child, what they found was when West African women would come to this country, they still had the same infant mortality rate as white women, but their children, their daughters, began to have an infant mortality rate that resembled that of African American just after one generation of being in this country. They were able to directly relate infant mortality rates to racism. It's directly related to racism and the socioeconomic factors that contribute. African Americans' life expectancy is 6 years less than our white counterparts. 18.7% of all African Americans 20 years of age have diagnosed or undiagnosed diabetes, compared to 7.1% of non-Hispanic white Americans. The risk of diabetes is 77% higher among African Americans than non-Hispanic white Americans. When it regards cancer, African Americans, we are diagnosed later. Cancer is diagnosed later in African Americans. And then a few more statistics. We have the highest rates of cancer-related death. Heart disease claims 50 more African Americans than our white counterparts. 49% of HIV-infected African Americans, of HIV-infected Americans are Black, and 86% of children living with AIDS are African American. So we can see where there are some clear disparities in healthcare with some of these statistics. So we, in this section, we've looked at how the African American body is impacted through chronic stress and some of the socioeconomics that contribute to overall lower health outcomes, poorer health outcomes. What I want us to now do is to transition and look at how this history of trauma has contributed to how African Americans perceive their own health and what some of our health behaviors are. So we're going to kind of pivot a little bit. So poor health comes and cultural identity, embracing poor health as a cultural norm. The power of belief. What do you believe? Now, if I have not learned anything in this past year and a half, 2 years since COVID has completely changed the way we live, is what you believe has power. What you believe has power. And I think those one of those things that like you hear growing up, like, oh, if you believe it, you can achieve it. Or if, you know, whatever you believe, so it is, or some quote to that example. We hear it all the time, but to really see in person, when what you believe has power. How can belief impact our perception of health and healthcare? One, we inherit counterproductive beliefs. So if we have a counterproductive belief about a vaccine or about another area of health, it's something that is often inherited. And if we believe it, we act out on it. What we believe about our health diagnosis, belief impacts that. How we believe our health diagnosis can be treated. Our willingness for treatment compliance and how we value medical advice. All of this is impacted by our belief and our perception. So if we have a history or family or community legacy of trusting the medical system, that is going to come out in the way that we act and behave, and vice versa. Would you all agree with that? Do you believe that what you believe has power and impacts greatly how you engage your health, your own health? I said, absolutely. Absolutely. For example, there may be people who are vegetarians. At one point you were not. If you did not believe that certain foods impacted the way that you felt, if you believe that going to the doctor is not effective, or it's going to come out in how you behave. So think back to just some of the things that we have discussed with regard to the Black experience in healthcare. How is that going to impact one, what we believe and how we behave when it comes to our health behaviors. So I'm going to be using diabetes as an example. Diabetes and the Black community. I like to say that we have a toxic relationship with diabetes in the Black community. It's toxic. Okay. Diabetes, here are the facts. In 2018, non-Hispanic Blacks were twice as likely as non-Hispanic whites to die from diabetes. African-American adults are 60% more likely than non-Hispanic white adults to be diagnosed with diabetes by a physician. In 2017, non-Hispanic Blacks were 3.2 times more likely to be diagnosed with end-stage renal disease as compared to non-Hispanic whites. And in 2017, non-Hispanic Blacks were 2.3 times more likely to be hospitalized for lower limb amputations as compared to non-Hispanic whites. A very toxic relationship, as I would like to call it. Now, I believe as a Black woman that this is greatly related to not only those socioeconomic barriers and the chronic stress, but also our perception and how we have come to embrace some of these poor health outcomes as a part of our cultural identity. And I would like to speak, and I would really am interested in hearing the perspective of other Black people when it comes to this perception, like how you see in your own community and family, how we engage some of these poor health outcomes. So who's familiar with this movie, Soul Food? Has anybody seen it? Anybody seen this movie? Everybody's saying, yeah. Okay. So this movie is called Soul Food. It came out in 1997. I remember because I was 7 years old. And I remember when my family got it on VHS and they watched it in the living room in front of my grandmother's really, really big, just a big box TV that's out on the ground. And I couldn't watch it because there was a few scenes. I remember like it was like night and day. And as somebody stated, they said classic. It is. If you are African American, this is just one of those movies that is just a Black classic since the day it came out. This movie is about a Black family, their ups, their downs, the struggles of traditional African American family, and how they come together over soul food. And soul food, you have scenes where they're cooking the food, they're cooking the pig's feet, collard greens, fried chicken, mac and cheese, candy yams, all of this good food. So the entire movie is kind of surrounded by this theme of food as a healer and as something that brings us together. But unfortunately, the food that is often utilized is completely detrimental to our health and makes us sick. And that's just the reality of it. But it's truly embraced as a part of Black culture. In this movie, you see Big Mama. This was Big Mama. She was wonderful. She was the matriarch of the family who held everything together. Everybody had a storyline, and she was the one to kind of hold it together. And she ensured that no matter what was happening, every Sunday the family got together for this traditional soul food dinner after church. And that is common in many Black families. And in the movie, Big Mama has diabetes. You see her going to the doctor with her kids and them telling her, Mom, you shouldn't be eating that. And she said, nah, go on, I can do it. That strong Black woman perspective. And eventually she ends up having a leg amputation, and eventually Big Mama ends up dying. So what I have found and believe is that oftentimes in the community, diabetes and embracing certain foods as a part of our culture is a part of kind of an accepted health outcome. Diabetes is relatively accepted as okay within the community, right? And it's such a major part of our culture. And soul food in particular was created during a time when it was like we were as slaves, we didn't have a whole lot. We took what we had and we made it work, and we made amazing food, flavorful food from it. However, it has been counterproductive to our health. So I want to show this video, and I think this, Laura, I'm going to get into that's strong. As a matter of fact, I'll touch it now. What effect do you think the pressure to be the strong Black woman living up to the stereotype has on accepting suffering? Absolutely. This is a perfect example of it. Big Mama had all kind of stuff going on in the family with her kids. Everybody was having an issue and she felt like she had to be the one to be there to take care of them. Number one, she did not take care of herself. She never made herself a priority. That's very, very common with the matriarchs in our family. Frankly, as Black women, we have not been taught to take care of ourselves as a culture. We don't really, we're just now, I feel like, really learning what that means to self-care. We come from a culture of slavery and a culture of survival, where that is the mentality that has often navigated how we go throughout life. And it's, as a strong Black woman, you can handle it. I don't need to go to the doctor. I'm good. She wasn't good. She was never okay. Like, diabetes is not normal. I want to say that again for just everybody. Diabetes is not normal. We've come to accept it, but it is not normal. So Big Mama has this diabetes and she does not make it a priority. She doesn't feel like it's something she has to engage. I have aunties like that. I have people in my family who have embraced diabetes, hypertension, high cholesterol as a normal part of being Black, and it is not, and it does not have to be. And so this idea of being strong keeps us, I think, oftentimes sick because we're not engaging the help, especially through the medical system, that we should be. So here's another clip. And then this clip, and this was meant to be funny, but I feel like it's a perfect example of how poor health outcomes is a part of cultural norms. So this is a picture of, I can't think of his name all of a sudden. Oh my God, what's this? This was this guy's name, Tracy Morgan. Tracy Morgan, okay? And I hope you all can hear it. So as you can see, this was an everyday clip or everyday scene in a TV show with Tracy Morgan that was meant to be funny, but it highlights a unfortunate mentality that is often found in our community where this idea of health is not a priority. Now, I think it was Janae. I want to address what you said because I think it's important. You said I would like to challenge the notion that we come from a culture of slavery. When Africans were taken from the continent, they were not enslaved. They took teachers, doctors, leaders, mothers, and fathers. Absolutely. Let me clarify my statement. When I say a culture of slavery, I was not referring to anything prior to colonization. I was referring to what happened to us once we became slaves. Once we became slaves, slavery created a culture for us, oftentimes dictated by trauma and survival. And I think that we are continuing to work hard to disengage and detach from that slave mentality that I believe that still exists in our community. No, we did not come from slaves, but there was a slave culture that was created once we became slaves in this country. And that could have been the way we had to engage relationships, the way that we had to engage our children, the way that we had to engage planters and our masters created a culture for us during that time. And it was all a very toxic culture. And unfortunately, we're still seeing the effects of it today. Does that clarify what I'm saying? Yeah, we had to engage to survive. Absolutely. Thank you, Janae. I'm happy I was able to clarify that. All right, so you see how, if you look at our history, poor healthcare, remember, going back to slavery, going all the way back to slavery, we did not enjoy going to the doctor. It was not a pleasurable experience because of the trauma that was associated with it. We often have poor health outcomes, and because of various socioeconomic barriers and stressors, making our health a priority has not been something that we have always had the luxury to do. And as a result of that, we have come to embrace certain poor health outcomes as a part of being Black, as a part of being the strong Black woman, or as a part of our cultural norms. All right, so when we're looking at hospital admissions per 100,000 for lower extremity amputations. So if you look, African Americans are 2.3 times more likely to be seen in the hospital for lower extremity amputations related to diabetes. And then when we look at those who have end-stage renal disease, we are 3 times as likely than our white counterparts to be seen in the hospital for end-stage renal disease. And let me say that prior to becoming an essential worker, I worked on the telemetry unit, which was the heart failure unit. And again, I'm new to the medical social work, so I don't know a whole lot about the heart, if you will. When I was on the heart failure unit, what I found was a lot of our patients had diabetes. Diabetes can cause issues with your lungs, which can create fluid around the heart, and they are all directly related because, again, our body is a system. We can't just kind of block one organ off from the other. If we have an issue with one, eventually we're going to have an issue with them all. Hospital admissions per 100,000 for uncontrolled diabetes without complications. We're 3.3 times more likely to be seen in the hospital due to diabetes, due to complications from diabetes. So it is around 10:30. Yeah, 10:30. It's about 10:30. What I'm going to do is, let me see how much is left in this little area. We're going to take a little 15-minute break. I see we can ask some questions. I see some comments in the chat box. Yeah, sure. This is specifically referring to type 2 diabetes. Type 2 diabetes is the diabetes that can be most controlled and is most often caused by stress and poor diet.
And Ms. Works, did you want to take the questions now, or did you want to do them after break? I'm fine either.
We can take a few questions now.
Okay, so we had one from earlier that I was holding off answering till now. So someone had asked, along with the medical mistrust, do you believe that many African Americans might also come to believe some of the falsehoods that they hear, such as the idea they should be able to handle pain better? And maybe this creates a burden for them.
Absolutely, absolutely. It has affected, and that's what I really want to highlight, that the events that took place have affected us, not only our bodies, but how we see, how we view our own health and how we are willing to engage it. It has impacted all of those things. So absolutely.
Thank you.
Angela, yes, I was like debating whether or not I was going to say it, but since you said it, this is especially true in our Black men. When I'm in that hospital sometimes and I'm just trying to get, for example, we may have older Black men, especially. The younger Black men are kind of more hip to health, but the older Black men, it can be a struggle with men in general, but Black men especially, just that. And a lot of times what I'm realizing that they're scared. And we don't speak to that often. I had a gentleman, he was older, he was a former military. He had to have been 75. And I'm telling you, everything was no. He needed to go to rehab. No. Why not? Because I can go home. I can do this. I don't need nobody telling me how to. I see it often. And I don't think that it's a stereotype. I think that African Americans have just a greater distrust for the system, and it can be very difficult to get them to comply with medical treatment. Were there any other questions before we take our break?
Thanks. Yeah, so someone had asked, do you feel it's more the medical system not believing a Black person's pain, or more about the hesitancy to go into the doctor as quickly, or maybe
with regard to the medical mistrust that exists? I think it's both. I think that it's both. I think that one has created the other. I do also believe that because of our negative experiences, oftentimes African Americans will have perceived poor treatment when that may not have been the case, but because of that traumatic history and that collective memory, as I shared earlier, I think it's just a cycle. I don't know which one contributes to the other. I think they play off of each other.
And then there was one question earlier. Someone said there was a study on the effects of acute stress on young African American women who committed suicide in the 1980s, as more African American women were coming into universities. And so they were asking, could this be an effect of generational trauma?
I'm not familiar with that study. I think it's a possibility. I'm not particularly familiar with that study, so I think I would have to know more. If you get the link and you're able to post it or send it, I would love to know more about it, but I really can't say because I don't know all of the details or what other contributing factors could have caused those suicide rates during that time.
Absolutely, thank you. And someone had also asked maybe how the pressure of masculinity could factor into some of the African American men being less willing to seek treatment, I think is the question.
Absolutely. In general, again, I think that toxic masculinity is an issue in general, but I think that it is especially profound in our communities. And I think it's a contributing factor. I can't give a statistic of how, but absolutely, you know, if you are feel as though you have to be tough all the time, you're not going to want somebody to check your prostate. It's just kind of how it goes. And we see that reflected in those high death rates. And again, cancer being diagnosed in later stages, I believe, is also because of a resistance to get treatment. You don't want to get your colon. It's not very masculine to get your colon, you know, checked. You know, nobody wants to do that. So I think there's definitely a contributing factor.
And then I see one more that maybe we can take, and then we'll probably good time for a break. So someone had said that they've worked in healthcare for a long time in many settings, and it seems as though they've encountered a lot of African-American clients who've been more hesitant to stop medical treatment or choose DNR, even when there's no benefit. So they said this maybe could explain why the mistrust in the system and maybe just a belief that the system is giving up on them.
I think that there is that, but I also believe that that has a lot to do with religion, because, you know, we'll have grandmother 95, full cold, praying for a miracle. I see that a lot. So I think religion plays a big factor into that as well.
Okay, thank you. So I don't see any other questions at the moment. Just a reminder for folks, when you do have questions, if you could please be sure to put them in the Q&A, because in the chat, it scrolls so fast that they can get a little bit lost.
And you guys are asking really great questions, so we want to make sure we get them.
Yes, thank you so much. And we will circle back for more questions later. So at this time, I think it's probably a good time to go ahead and take our break. So we have 15 minutes. I'm showing that it's about 10:35 right now. So let's plan to come back for 10:50. And if you're able to stay logged in, it helps just reconcile our attendance records. But if you need to log out, just please be sure to log back in by 10:50. And a quick reminder, we will not have audio during the break as we are all muted. So we will be resuming again at 10:50. So we'll see you back soon. Thank you so much. All right. So it looks like it's just about 10:50. We'll give folks a moment just to come back from break. And Ms. Works, we did have a quick clarifying question I thought we could take really quickly.
Okay.
So someone had said economics, scientific racism are two historic factors impacting disparity. What was the third? So I guess this was something we discussed
economic
earlier.
Policy.
Okay.
The 1807 policy, that was the 1807 act to I forgot the name of the 1807 act to stop the importation of slaves.
Okay, so it was policy that was the third. Thank you so much.
No problem, thank you.
Okay, well, I don't see any other questions at the moment. Quick reminder again, if people do have questions, please be sure to put them in the Q&A so that we don't miss them. And whenever you're ready, we'll go ahead and resume.
All right, let's go, jump into it. So in this, the last section of part 2, we're going to look at COVID-related health disparities. So again, it's been about 3 years now since I've been in medical social work, and I was working telemetry. That was for about a year, and then COVID happened. And when COVID happened, that's when I was transferred to our ICU, turned into the COVID floor. And I became the social worker for that unit. So I really got a up close personal look at some of the disparities with COVID-related health issues. And I like to review just a few of those. So one, COVID's devastating impact on African Americans. Here you see this, this graph that shows the amount of deaths COVID death in the African American community in relation to the state or city's population. So if you look at Louisiana, which right now is continuing to have such a major um, impact, is still continuing to be impacted by COVID. They make up 32%. African Americans make up 32% of the state's population in Louisiana, but we made up 70% of their COVID deaths, which is astronomical. In Illinois, we make up 15% of the state's population, but we comprise 42% of the COVID deaths. In Michigan, there's 14% of the population, and we have 41% of COVID deaths. If you look at North Carolina is what you would ideally want your statistics to look like. 22%, we make up 22% of the state's population, and we comprise 22% of the state's deaths. That's what lack of disparity, if you will, would look like. In Chicago, on the other hand, we make up 30% of that city and 69% of the COVID deaths. So you see that we are being disproportionately represented in COVID deaths around the country. So some of the COVID-related discharge barriers, because working in the healthcare system, and many of you, the majority of you work in healthcare, know that discharge planning, is there anybody who does discharge planning? I want you, if you're in the comments and you do discharge planning, I'm interested in seeing that. You do, Brianna, Laura. Okay, so you all know the Anna said she used to, Nicole, the barriers that can take place and took place during that time. So for me, working in an inner city hospital where we have a very large homeless population, as well as a very large population of our patients who live under the poverty line, there were unbelievable discharge barriers. One being housing, because oftentimes when our patients would leave the hospital due to COVID, if you were homeless, leaving the hospital, you can't be homeless anymore because oftentimes your body was too weak to survive the streets. So having to find housing in those scenarios. And also, oftentimes we had patients who would leave the hospital needing oxygen because of the lasting impacts of COVID. And if you don't have a house or anywhere consistent to plug your electricity, then you're going to have a very difficult time with having your oxygen. Somebody said housing is also an issue leaving the prison. I can only imagine. I worked in prison for 2 years. I can only imagine. Affordability of prescriptions. Now you have a lot of prescriptions that people are not able to afford. We had an increased transmission due to the inability to socially distance and multiple family members residing at one residence. So especially in the beginning, because in the beginning, we didn't have really anything set up in our state to house people for quarantine purposes and isolation purposes. People were stuck in the hospital because it was, I can't go home because my mom lives here and there's not enough rooms for me to isolate, or I can't go back to this house because I'm going to spread this disease. That created another barrier. And then oftentimes there were challenges to child care and just major disruptions in everyday living because people were hospitalized. And I'm sure that you all had the same experience. Brianna saying that some people were discharged to hotels. Yes, we did. So check this out. Before we had our hotel set up, the governor, Governor Kemp decided that they were going to get this area in rural Georgia to put all of the homeless COVID positive patients. It was a terrible idea. They found the area literally in the woods, and they were going to collect all of these people from the city and all of these predominantly Black people and take them all the way to the country during a pandemic, the first of its kind. Did not go over well. I remember even reaching out to my state representative, like, I think that we're going to run into some issues of trauma here. This is not a good idea. So they were able to get some hotels. And we also had the World Congress Center for those who had greater needs after discharge. We had the Congress Center. I won't lie to you. If you told me that I would still be doing this presentation with these issues still being present, I don't know that I would have believed you. It's been heartbreaking to see it come back, if you will. Our hospital actually celebrated the end of COVID. We celebrated that we beat COVID. We had a little parade. We were really excited about it. And here we are. Our hospitals are at a capacity that I don't know that I've seen even when COVID first started. So it's been very draining for all of us involved. So when we're looking at the mistrust of the healthcare system, I'm just gonna wait and see. That's what I heard when everybody talked about getting the vaccine. I'm just gonna wait and see. Are you getting a vaccine? I don't know. I'm just gonna wait. I'm gonna see. You know, nobody really wanted to get in. Let me say, I was the first one to sign up. I got mine early January. One of the first people to get it. But the general consensus, especially in Black communities, was I'm not getting that vaccine. I'm not letting them people put that inside of me. And I'm sure many people had similar experiences with other people in their communities. So there was this grave mistrust of the healthcare system that we saw specifically as it related to the COVID vaccine. So medical mistrust, Penn Medicine, during the first 2 weeks of their vaccine rollout, just 22% of eligible Black employees compared with 62% of eligible white employees got vaccinated or signed up to receive the shot. That is almost 3 times the amount of white people were willing to get that vaccine versus African Americans. And of course, African Americans are disproportionately impacted by this virus, yet we are least likely to get it. I remember when I got a vaccine, and I'm just talking about the conversations that I heard working predominantly at a predominantly Black hospital. I remember one person, did you get it? I'm like, yeah, I got it. Which one did they give you? I said, I got Moderna. Oh, okay, I'm just trying to see, because I thought they were giving all the Black people Pfizer and all the, I got Moderna. I'm just trying to make sure. There was so much suspicion and so much mistrust as it related to this vaccine. It's been unbelievable. And I really thought that in time, as people started to see those numbers go down with increased vaccination, that it would clarify a lot of the mistrust, but it's so much more deeply rooted than even I understood. So another statistic, 37% of the 600 doctors, nurses, and support staff at Roseland Community Hospital have been vaccinated, even though healthcare workers are first in line. Many holdouts come from mostly Black working class neighborhoods surrounding the hospital areas hardest hit by the virus, yet plagued with vaccine reluctance. This unfortunate irony is that we are most impacted by the virus. So as I was sitting here, ironically enough, as I was sitting here during our break, I received a CNN alert to my phone that states these 5 states have less than 10% of ICU beds left as COVID-19 overwhelms hospitals. And it says Alabama, no shock, Alabama, Georgia, Texas, Florida, and Arkansas, no shock, have less than 10% left of their ICU bed capacity. And it goes on to state that the overwhelming majority of those who do not have, who are in the hospital, who are dying of COVID, are unvaccinated. My hospital released statistics earlier, a few weeks ago, and I think at one point they were saying that we are currently, with the 11 hospitals that we have 590 people that we are treating for COVID. Of those 560 people, I believe. Of those 560 people, 504 of them are not vaccinated. So really large numbers. The mistrust runs deep, and you know that it runs deep because people are seeing that the hospitals are full of unvaccinated people, yet they're still reluctant to get this vaccine. So I'm going to actually show a video now. This video, well, it explains itself, and we'll discuss it afterwards. Julie, were there questions? I think I see some.
Oh yeah, sorry. I just wanted to jump in. So there were some questions about that slide with the rates and some of the different states that were showing disparities. So one of the questions was for the states like North Carolina, where it was reflecting less disparity than say Louisiana. Were states like North Carolina, are they doing something differently, or is it just like kind of coincidental?
I don't know, but I'm going to be honest. I doubt that North Carolina is doing something different. I think it might just be kind of how it plays out. I don't know. I don't want to assume, but historically, I don't think they've been the most progressive when it comes to the way that they go about these crises. I don't know. I could be completely wrong.
And someone had asked, do we happen to know what the vaccination rate is in these states.
Oh, no, I just need to add it to my next PowerPoint. I don't know.
Okay.
And when I initially did this PowerPoint, the vaccine had just come out, so there was a lot less information at the time. But that's been some months ago, so I need to get some updated stats. I don't know, but if I'm able to get that information, I can send it to you.
Okay, thank you. And finally, someone had asked, is there a correlation with vaccinated versus unvaccinated? I'm not quite sure what that means, but if that individual is able to add maybe a clarification to the question, we can always come back to it. So.
Okay, I mean, the correlation is that the people who are dying and the people who are sick are unvaccinated, largely unvaccinated. And those who are dying and sick and who have been vaccinated, 9 times out of 10 are elderly and have, they're vulnerable already with compromised immune systems. So what we're seeing is that the current crisis is largely due to unvaccinated people, and that it is not the failure of the vaccine to work. And also, I've not seen anybody in my hospital come there because of COVID vaccine side effects.
Interesting. And finally, someone just commented in the refugee community, some of them did not come forward due to fear of what might be in the shots.
They didn't come forward. You're talking about the refugees, Afghani refugees, are they?
Not sure. So for the participant who had made that comment, if you wouldn't mind clarifying.
But you can clarify in Q&A.
Yeah, you can add another question in the Q&A to clarify. So we can come back if they are able to clarify that one.
Okay, absolutely. So
Thank you.
Okay, so I'm going to watch this video. This is one of the, I believe, direct descendants, either the granddaughter or daughter of one of the Tuskegee syphilis, men of the Tuskegee Syphilis Project. And we're going to kind of watch what her experience has been with this vaccine.
Silence and solitude. Lily Tyson Head needs a bit of both. Silence and solitude. Lily Tyson Head needs a bit of both right now, as she reflects on the trauma of her family's past, while leaning on faith.
I'm sorry. I don't know how I did that. Trying to get the subtitles on did not work for me.
You were definitely in the right place. If you just click that CC button, does it pull it up again?
It keeps forwarding. Let's see.
Silence and solitude. Lily Tyson Head needs a bit of both right now, as she reflects on the trauma of her family's past, while leaning on faith in the future.
Things have changed. Things have gotten better, but still needs to get a whole lot better.
All week, celebrations across the country hitting a fever pitch as the new COVID-19 vaccine.
Would you be able to make it full screen by chance, or is it?
This long-awaited moment providing hope for so many amidst the pandemic.
Let me see. Yeah, I can make it full screen. Give me one moment.
Okay, sorry.
Well, no worries. It's just going to take me to the. Here we go. Gotta love technology, right?
If not, we can just watch it within the PowerPoint.
Lily Tyson Head needs a bit of.
I think it's going to just keep going back. I don't know why it's giving me challenges. I'm sorry.
Oh, that's fine. We'll just have it play in there. Thank you.
Hi, everyone. George Steff.
All right. So I really enjoy watching that video because it shows, as the narrator said, victim to victor. And that's really what this is about, is empowering ourselves to make positive changes when it comes to our health, despite the history of trauma. I see there's a question, Julie, if you want to get to that question before I go to the next slide.
It was actually just that comment about the refugee community.
Okay.
So, there is one. Another comment here. Someone said, the conversation that I have with the Black community that are hesitant in getting the vaccine is that technology is driving everything, meaning it does not take as long to develop a vaccine as it did in the past. So that's one of the other comments that came.
Absolutely. And then just the nature of, this was a pandemic, so everyone in the world was affected. That allowed for more money to complete the vaccine. That also allowed for more participants. There were more people willing to participate in this, in these trials because of the nature of the virus. And also there's a part of the vaccine that was already actively being developed. So there was that was an advantage. So checking in, someone already asked the question earlier, but there we go. As we check in, I want us to really kind of process what we've learned up to this point. We looked at the historical trauma. We looked at some of those contributing factors that cause present day healthcare disparities, such as economics, medical experimentation, policy, poor access to health, lack of consent, the collective memory that we carry within the community as it relates to these experiences. And then we also looked at how, as African Americans, sometimes we may embrace the poor health outcomes as a part of our cultural identity, all essentially a part of the historical trauma, or related to that historical trauma. I'm definitely motivated to get the vaccine. I cannot reiterate how I really did not expect at this point to see so many people still resistant to the vaccine, especially after seeing death around them and in their families. So our next section, we are going to look at the effective strategies to build trust and empower agents of change. It's good to know the information. It's good to have a historical perspective when you're looking at issues of healthcare disparities, but it's also important to know how I can apply this, okay? So we're going to look at some practical strategies that can use to not only build trust, and I want to reiterate, not only build trust when it comes to the healthcare system and those who work in healthcare, but to that other percentage of individuals who are not in healthcare, who may be working in various settings with African American community. I've found that using this relationship approach and perspective is effective and empowering agents of change. So as we get into effective strategies, we want to look at the power of relationship. If this pandemic has taught us anything, it has taught us the power of relationship. Many of us experience loneliness, being around throughout this pandemic, being around others, being seen, feeling validated. All of those things are a necessary part of the human experience. And as this pandemic in many ways have forced loneliness, we've seen a substantial increase in anxiety, depression, suicide, mental health, and other non-COVID related health issues. Research over the past 50 years has demonstrated, because I know that this is primarily looking at healthcare, but I want everyone in various sectors to understand when we look at trying to create change, especially in the therapeutic relationship, research has shown that over the past 50 years, there has been one primary factor more than any other that contributes to an increase in positive change, and that is associated that is the quality of the relationship between therapist and the patient. So when we're looking at successful treatment, it's not so much the modality that you use. It's not whether you use Freud or someone else. It is the relationship you have with your client, and the quality of that relationship is what is oftentimes a motivation for change. Have you all experienced that when working with patients in various settings, where relationship has so much value and impact on how they engage, right? So we're going to use this perspective when we look at how we can kind of heal and mend the relationship that African Americans and other people, communities of colors, have when it comes to the healthcare system. So trust in healthcare professional and health outcomes. It says, from a clinical perspective, patients reported more beneficial health behaviors, less symptoms, and higher quality of life, and to be more satisfied with treatment when they had higher trust in their healthcare professional. There was evidence for upward bias in some of the summaries, but prospective studies are required to deepen our understanding. But from what we understand is that the studies show that there is an overall better health outcome, not just in your perceived treatment, but also in the actual physical body. So when we're looking at the power of relationships, we really want to start with empathy. That has really been a theme throughout the last year and a half, especially when conversations of social justice and race come up. We talk about empathy, really putting ourselves in the place of the individual and feeling what it is that they feel and experiencing what it is that we're experiencing, what they're experiencing, and operating from that place, okay? So empathy, I believe empathy is the foundation to building that healthy therapeutic or professional relationship with our clients. I don't know what's going on with this slide, but it is supposed to say empathy, relationship, and patient outcomes. So in a study of over 700 clinical encounters with patients who had the common code, those patients who gave their clinician a perfect empathy score reported that their codes were less severe and lasted fewer days than patients who gave their clinicians less than a perfect empathy score. In addition to their self-report of feeling better, these patients also showed a higher change in both nasal neutrophils and the cytokine. I don't know exactly what that means, but they showed a higher rate in their physiological changes and better outcomes when they rated their physician with a higher empathy score. So there's an empathy scale that's used, and it asks various questions about the physician's treatment, how warm they are, how engaging, how much you feel like they value you. And the higher that score was, the better the outcome for the patient. There was another study, in a study of 710 cancer patients in Germany, physician empathy was positively associated with improvement in patient-reported outcome of depression and quality of life. And I mean, that's pretty easy, not easy, but I guess it's not difficult to believe that when you have someone, a physician or a healthcare professional who is invested in you, and when you can tell that they have value in you, you're naturally going to feel better. And when you feel better, your body responds to that. So there is a direct correlation between empathy, relationship, and health outcomes. In another study of over 20,000 patients with diabetes, researchers found that patients of physicians with high empathy scores compared with patients of physicians with moderate and low empathy scores had a significantly lower rate of acute metabolic complications. So the more the physician showed empathy, the less diabetic complications the patient experienced. I think that's absolutely fascinating how the mind and brain collaborate together in that way. And that was no small study, that was 20,000 patients. So the benefits of empathy in healthcare, you have overall better care, greater patient satisfaction, higher levels of hope, increased patient trust, and ratings of clinical competence. If you work in a hospital, we all know how important those patient satisfaction scores are. When we have practitioners, not just doctors and various physicians, but medical professionals who are in that setting, who have empathy, those patient satisfaction rates are going up. It shows an overall improved workplace, better job satisfaction, and improved health, reduced pain, reduced mortality, improved medication adherence. I think that this is so crucial. As stated, when Julie was reading my bio, I did work for a community mental health ACT team, assertive community treatment. I don't know how many are familiar with ACT, but I was an ACT team lead for about a year or so. And during that time, we worked with people who are SPMIs or severely and persistently mentally ill, so often psychotic and very difficult to manage outside of a hospital setting. And our job was to manage them as best that we could, so that we could kind of keep those hospital admissions down. That was our job. And what we found is no matter what type of treatment we provided, the medication adherence rate was improved with our relationship to the patient. We saw them often as a part of the ACT model. You see patients about 3 to 4 times a week. And when we had positive relationships with them, they did so much better simply because they would be more willing to take their medication. And I know that that has been true for many of you, especially some of you who may work in a prison system. The better that relationship is, the better those overall health outcomes are. So we're going to look at using cultural differences to impact change. We all know that we are different, just like that we're all the same in many levels. As humans, We share the same feelings. We often share the same thoughts and desires. We have the same fears, being humans, but I believe that we do have cultural differences. And I believe that when we embrace those cultural differences, we can utilize them to impact change. So with that said, this is this model, while it can be used with many different people and cultures, this is specific to how African-American communities engage relationship amongst each other. So one of the resources that we have to us as practitioners is fictive kin. So we want to utilize fictive kin to impact health outcomes. I have in quotes, that's my play cousin. I put that in quotes because oftentimes fictive kin is a major part of the African-American community. And that's my play cousin. I grew up having people who were cousins who weren't really my cousins. But the relationship that we had and the social obligations that we had to each other was as though they were family. And one of my experiences working in the first hospital setting that I told you about that was more affluent, my coworker, my office mate, she was a white woman. And I remember one day she came into the office after visiting with a patient and she was somewhat perplexed. She's like, I have a question. Why is it that oftentimes when I'm asking patients, like Black patients, about the relationships, they'll say cousin, aunt, and then as I ask more questions, I find out that they're not really related at all. And I explained to her the power of fictive kinship and why it's important, how it became important. If you look at our history as being slaves in this country, we were on a plantation. We were on a plantation with other slaves. Sometimes they would be related to us. Oftentimes they would not be. Most of the times they were not our biological kin. So they would become fictive kin and they would play the roles of important relationships. So we would be the aunt, you have a mom, you could have a grandmother, cousins, brothers, and sisters. And these roles were vital in our survival as a community. So, and briefly, fictive kinship involves the extension of kinship obligations and relationships to individuals, specifically not otherwise included in the kinship universe. So when working with a community that has been disproportionately left out of access to appropriate healthcare and is also disproportionately impacted by negative stereotypes within healthcare, building a relationship is crucial. Not only building a relationship with the client is crucial, but utilizing the important and the positive relationships that the client has to impact change. This is very important. Again, whether you are working in the healthcare system or not, whether you're a therapist, where you work with families, children, using fictive kin to bring about change is very important. Because what often happens is, let's say you're a therapist, like you're not necessarily in a healthcare setting, and you're working with a patient who has a lot of what we say negative influences. They live in a community that is high poverty, lower socioeconomic status, and there are just a lot of barriers. If you're working with a teenager, let's say, there may be influences that that teenager has that you don't consider positive. But oftentimes in our profession, we will look at a relationship that an individual has in the community and we'll see it as negative without looking at the bigger picture. I was working with a gentleman, he was justice involved youth, and I was working with him inner city in the metro area. And he had people in his life that he loved and adored, but who did and participated in things that I would not want him to participate in, and that I believed would just lead him down a negative path. And so my natural instinct to him was, you need to stay away from these people or away from these things. You need to stay away. And that's kind of the advice that we give, but it was so unrealistic. And it was unrealistic simply because he lived in this community. So yes, he had a cousin close to him that did things that I did not necessarily want him to do. However, that same relationship also played another vital role in his life and had positive influences. So we can't just cut out a relationship without looking at it in its totality. And oftentimes we would do that. But if we use fictive kinship to help, what we're doing is we're teaching our clients to take positives from those relationships and build on them for their own outcome. So for example, with this particular gentleman, he was not taking his medications, and he had some psychosis, not taking his medications, wasn't going to school. And he would often mention a relative who I think he sold weed. And I was like, I was really like hesitant, like, I don't want this individual impacting you. One day I decided, because he just always talked about this cousin, I reached out to the cousin. I got his contact information. I reached out to him and I'm like, hey, listen, I'm having a difficult time with your little cousin. Just trying to get him to make certain changes. And we're going here back to back, week to week, and nothing is working for us. Nothing is working. But he always talks about you. He talks about how much he looks up to you. And I can tell by the way that our conversations go that you have a powerful role in his life. Oh, yeah, okay, yeah, I get it, I hear you. Is there any way you can just help me keep him on track? He's missing school. When you see that he's not in school, can you just let him know that he needs to get to school, or remind him what our goals are? Oh, yeah, because guess what? That same cousin who may not be making the best decisions, he still very much loves his little cousin and wants to see him do well. And oftentimes we forget that when we're looking at our relationships. And what I did was I was able to utilize the positive nature of the relationship to build on it, and it truly brought about change. So utilizing fictive kin, even in the healthcare system, if you have a patient who you're continuing to see because of failure to medication adherence, or other barriers that's preventing a positive change, utilize the relationships that patient has in their life, because oftentimes those relationships are far more powerful and far more impactful than the time that we spend with the patient. Do you agree with that? Do you see some? I'm seeing some. Absolutely. So I was saying fictive kin is a very powerful in African American communities. And it really goes back before we ever came here. We are a tribal community people. It is in our culture. I believe it's in our DNA. We are just very tribal. And that is one of our cultural differences. Every community is not like that. Okay. Every community does not have a tribal nature to it. And that's okay. It's neither good nor bad. It's just is what it is. But you want to utilize that cultural difference to help impact change for our patients. This is very difficult to see. Oh no, it's so hard to see. This is called the philosophical aspect of cultural differences. And it is a theory supposed by Dr. I think his name is Dr. Edwin Nichols. And what he did is he looked at various cultures and he said, okay, we all have different axiologies. Axiology is how, the value that a culture places on a particular thing. So as a culture, we have different values, we have different axiologies, we have different ways of thinking about time. We have different ways to measure. And he looked at our historical backgrounds and said, okay, he kind of grouped us in different categories based off of those similarities. So when you're looking at the African American community, the Latinx community, and the Arab community, we often, the highest value for us is in the interpersonal relationship with one another. And so if you want to help to impact change, you will look at those relationships. Now, if you're looking at the Asian community, he said the greatest value is in the group. So for example, if you look at even the way we handled the COVID crisis, when you look at the COVID crisis, the Asian community as a group, if you saw China, what was happening in China, they were looking at the group benefit. The value was in the group. So it was not difficult to get them to stop going out. It wasn't difficult to get them. It was understood this is a group effort. And different cultures have different values. The Native American communities, their highest value is often in the spirit realm and in the spirit world. And then in the Caucasian community, the highest value is often in the acquisition of the object. And so none of that is either right or wrong. It is just those differences that we have in our cultures. And it's important to utilize those cultural differences to impact change, right? Because what works for one does not necessarily work for all. And oftentimes we, especially in social work, we put a barrier to how we can engage relationships. So like the code of ethics gives like a very clearly defined, somewhat defined way of how we engage relationships. And that may pose a challenge to some African Americans because we are so interpersonal and community minded. It may be difficult to, I think that it's important to note that there can be a challenge when it comes to that way we engage relationships, okay? So when we are looking at, and I see there's a question, Julie, you could go ahead and get to it before I go to the next slide, if it's one that hasn't been asked already.
Sure. Someone just asked if you'd be able to clarify the name of the author of this chart.
Yes, it is Dr. Edwin Nicholas. Edwin Nicholas. And if you type in the philosophical aspect of cultural differences, you will see his name pop up, and he has lots of lectures on this, and he's able to really get it really deep into it. This in and of itself could be a whole presentation. So we look, so I showed this to say that we culturally, we do have differences, and those differences should be utilized specifically and uniquely to help impact the change that we want to see in our patients. So as we begin, as we're looking at the racial and ethnic differences in extended family, we've already discussed fictive kinship. I want to look at the types of family. We know family is common ancestry. We're related through blood. Excuse me, you have friendships, a person whom one knows and with whom one has a bond of mutual affection, typically exclusive of sexual or family relations. And then you have fictive kin, which is a kinship based on social agreements such as friendship instead of adoption, blood, or marriage that creates a relationship like family. And it also, again, fictive kinship carries a social obligation. Okay, like if you're disloyal to me in our fictive kinship relationship, like that carries weight. So there was a study that actually looked at the racial and ethnic differences in extended families. The study looked specifically at Black families, Black Caribbean families, and non-Hispanic white families to assess how each group engaged these various communities: family, friendship, fictive kin, and also the spiritual or congregational relationship. So what they did was they used the solidarity model. The solidarity model is like a family model that it looks at the dimensions of a relationship. It looks at the association, how frequently you engage with the various individuals in these groups, the level of affection you have, the level of sentiment, and also how consensual these relationships are. Like, to what degree is this just tradition and belief associated with the type of relationship you have in these various groups: family, relationship, fictive kin, and then the church group. Okay, and so what this study showed is that looking at fictive kin, it shows both African Americans and Black Caribbeans were more likely to have fictive kin than non-Hispanic whites. African Americans and Black Caribbeans also reported having a significantly larger number of fictive kin than did non-Hispanic whites. In comparison to non-Hispanic whites, African Americans interacted with their congregation network more frequently, and in comparison to Black Caribbeans, African Americans indicated receiving emotional support from congregation members more frequently. Both African Americans and Black Caribbeans reported being subjectively closer to the members of their congregation than non-Hispanic whites. So now that's neither good nor bad. Oftentimes people attach judgment to those statements. I've been in presentations where it seems like people may get upset, like, oh no, white people engage their family too. We're not saying that that's the case. We're saying is that within the African American community, fictive kinship and that church community plays a vital role in relationship. And because we know that, because we have that knowledge, we should then utilize this knowledge. This is not insignificant. When you look at the church, when you look at fictive kin, this is a host of resources that we have in those groups that can be utilized to bring about change in the individual that we're working with. Okay. So we want to look at some other ways that we can really help people of color, African Americans, build trust in the healthcare system. And then also, again, in healthcare system also involves therapy. It involves the wraparound services and those emotional supports. We know we start with relationship. We want to look at relationship-based education. And I quote Dr. James Comer, a child psychiatrist. He says, no significant learning occurs without a significant relationship. Whether we work in a small agency or hospital healthcare setting, we must be intentional with how we provide information to our patients and clients. Information should be given from a very interpersonal space as much as the work environment allows. Our medical trauma is rooted in a lack of control, lack of consent, and poorly informed decision-making. Understanding consent and having, understanding consent, having informed decision-making and using common language with our patients is essential in building a relationship and providing relationship-based education. So what I simply mean by that is we're not just going to throw a pamphlet at someone about, like they give you whenever you go to the hospital, they print out these packets about your whatever disease ailment you had, and you go home and reread it. But when you combine that with a relationship, like a relationship that particularly shows value to the patient and client, you're going to have a better outcome. So when I sit down with my patient and I say, I want you to understand what this is saying, because I want you to make the best decision about your health, or using language that's simple, that one is really huge. And I've run into a lot of barriers myself. All of these things help us to empower our clients. But it also says, when I take my time to explain to you what's going on, when I let you know that I want you to know the information so that you can make the best decision for yourself, when I use language that you can easily understand, I am showing you value. And when we look at what historical trauma is, when we look at the experimentations, the lack of consent, the lack of control, it is deeply rooted, and there's a lack of value that was had for our community. So the way that we reverse that is by building that relationship and providing education connected to a relationship. When I take the time to explain your treatment, even as a therapist, it shows value. And it's a form of empowerment. I thought we had a question. Do we not have a question?
We did have
Julia,
a question.
Yeah,
we had a question that I'd asked for clarification on. So someone had
Julia,
and they're,
you went out a little bit, so could you repeat that?
Oh, I'm sorry. Am I back now?
I hear you.
Okay. We had someone asked if there are any studies regarding Native Americans and they said and their death rate. I think they mean as in terms of COVID-19, but I had asked for clarification because I'm not 100% sure.
There are, I don't have them in this particular presentation, just because of the subject focus was African Americans. And let me state that I don't want anyone to leave this presentation thinking that other communities, especially the Native American community, which is oftentimes just disproportionately impacted by various disease and lack of healthcare, those all have great value and they're all essential and important. I don't want to ever take away from that. The reason why there was a focus on the African American community is because this community has specifically endured such a long history of trauma connected directly to our lack of healthcare and to those disparities. But yes, I have heard some studies. I don't have them in this particular presentation, but I'm sure that they could be easily found online. Was that it? Were there any other questions?
I don't see any others right now, so thank you so much.
All right, so here are some things that we can do, especially if you're in discharge planning. Do this. One, again, use common language. Use common language. I had this experience, just wasn't that long ago, maybe about a month or so ago, where I was going through a chart, getting ready to discharge a patient, and it stated that the patient needed, that the patient was recommended for home health. So I went to the room, and this was an older lady. She was maybe in her early 70s, and her son was in the room with her. And I said, hey, Miss, whoever. And I said, looks like they want you to get home health. Is that something that you would like for discharge? She said, no, I don't need that. I said, okay. And I got ready to leave her room. And her son said, wait a minute, what is home health? And I started explaining, well, we can offer you, physical therapy at home, occupational therapy. We can get a nurse to come in. And he looked at his mom and said, Mom, don't you need that? And she said, oh, yes, I do. And in that moment, I realized that I was using home health, assuming that she knew what those services involved, and she didn't. And because I didn't make sure that she had a proper understanding, she would have left without a service that she did need. So using common language and explain throughout the discharge process, throughout the hospital process, what's going on with the patient. Also, you want to make sure you provide informed consent. I'm gonna be honest with you. I've seen us be somewhat unethical in this regard. So how many of you are familiar with the IMFM letters that we have to give to patients at discharge? Put it in the chat if you're familiar with that IMFM letter. I think it's from Medicare. So whenever we're discharging a patient from Medicare, I'll use this as an example. Okay, so if you don't know, that whenever a patient has Medicare, they have a right to, when they're leaving the hospital, they have a right to appeal their discharge. As a, Rosalind is familiar, when you, as a recipient of this insurance, no matter what type of insurance, Medicaid, Medicare insurance you have, if you have Medicare and you're leaving the hospital, a social worker or someone is supposed to come to you and say, as you're discharging, do you feel it's necessary for you to discharge from the hospital? You have a right to appeal. Here's the number if you feel like you need to appeal this discharge. Now, I have seen, especially in inner city hospitals where we may be overwhelmed with our beds, or we may have patients who are difficult patients, we'll kind of just get them here. Here's a form from IMFM letter and just get them to sign it, not explaining to them like this allows you to stay in the hospital longer than this discharge date. And I have seen over and over again where people do not explain that because they do not want the patient to be informed and say, okay, well, I'm going to stay, whether it's for a medical reason or not, I'm going to stay. We get a lot of homeless patients who may want to extend their stay. We don't inform them of their right, and they're not able to make the best informed decision for themselves. So this is something that whenever we have those situations where we have a patient who has to give informed consent, make sure they understand what that means. And you also want to guide their informed decision-making. So once a patient has been given all of their information, let them know if you go this route with your care, if you choose this particular rehab or this particular plan, this is what will happen. As Amy was saying, hospitals definitely do not want those explained correctly, and they don't. So as practitioners, it is our job to do that. And Anne said, I thought the patient risked having to pay out of pocket if the appeal was denied. That is true, but honestly, that's not very often where they end up having to pay. But even still, they should be given that option and told, hey, if you do this, you will pay. I've seen where patients have signed it and didn't know that that was a factor. We want to give them all of that information because this allows them to be agents of change and to make the best decisions for themselves. We're not here to change our patients or to make decisions for them. We're here to help guide. So here are some what I call relationship-based questions that you can incorporate into your healthcare assessment. I've done this because we have a standard assessment that we use. And I asked some of these additional questions, maybe one or two on each assessment, to give me a complete idea or a better idea of how my patient is willing to engage treatment. So one of them is, tell me something you want the doctor to know about you that has nothing to do with your health. This really helps to just humanize patients. I think that oftentimes we see a number or we see a diagnosis and we treat from that perspective, not remembering like this is just a person that has a daily life and jobs and kids. And I want you to know that that matters to me too. Two, what are some health concerns you have worried about over the past 3 months? Can you share with me a health experience you feel I should know about? Is there anything you would like to know about me, your doctor or your social worker? Is there any information? Is it normal to have concern? It's normal to have concerns about visiting the doctor, especially when your community has been negatively impacted by the healthcare system in the past. Is there anything I can do to make the experience more comfortable for you? These are questions that really open the door to relationship. You can't build the most amazing relationship with the patient when you're seeing them once a week or if you're seeing them just while they're in the hospital. But there are things that we can do, questions we can ask, assessments we can take to help make their experience better, okay? And this really speaks directly to some of the concerns that many African Americans have. All right, another resource, community partnerships. I don't see it enough, okay? There are grants, sponsors, local businesses who would be willing and excited to partner with you or your agency to collaboratively address the issue of health disparities in your community. You want to partner with people who are already trusted in the community. There are already agencies that our patients will use on a regular basis that are trusted, visible organizations in the community. we don't have to do a lot of work. We just partner with them. And by partnering and associating, it can be an initiative to help increase medication compliance. It can be an initiative to address diabetes, or whatever the specific issue may be for your community. Think about those community partnerships or those community resources that many patients frequent. For example, if you have a patient, like you work in a hospital setting, you might have a patient who goes to a particular clinic for follow-up, or you may have patients that utilize a particular food bank or particular school system. We can partner with these organizations. By partnering with them, that helps them to build trust in us and to see, okay, well, I trust this organization. I've been going to them for particular service or resource for years. And now that my hospital or agency is connected, that builds a better trust, and it allows for more hands to address those issues. So throughout the presentation, we've asked, we've wondered, how can we help to build trust and help African Americans and people of color to build trust in the healthcare system? I would say that I don't know that we are asking the right question. The question is, are we trustworthy? Is the organization, is the agency, do we have policies, procedures, rules that show value to people of color and that address the heart of many of the issues that individuals come in with as it relates to healthcare disparities and health trauma? That's the question that we have to ask ourselves. Can we be trusted with these fears? Can we be trusted with this collective memory? Because oftentimes when we do that assessment, not just internal as an individual, but as an agency, we will find that there's lots of work that can be done within our agency to facilitate a more welcoming and more inclusive experience. So empowerment through narrative, and I see we have a few questions, and then we'll open up for a few more minutes and we'll open up for questions. Empowerment through narrative. This is important because, again, our stories haven't been told. The Black story in general, not just when it comes to healthcare, but our stories have not been told. And we have to know those stories, learn those stories, and empower our patients through that narrative. We get to decide. We get to decide which way we go. And when we empower our patients and give them that decision, we allow them to be agents of change. So when we're looking at empowerment through narrative, we want to look at growth through resilience. And there is actual, just like we know of post-traumatic stress disorder, post-traumatic slave syndrome, there's one called post-traumatic growth syndrome. And it is the idea that we grow and we become resilient through trial and circumstance. In the video of epigenetics, when we were talking about the survivors of the Holocaust, the question was asked, so if you have a parent who has gone through this trauma, or if you've gone through this trauma, are you doomed to be depressed? Are you doomed to be sick? The answer is no. We can learn to grow. And a part of being a good clinician is being able to help guide our patients in recognizing the positive growth that has come through challenges. We've learned that negative experience can spur positive change, including a recognition of personal strength, the exploration of new possibilities, improved relationships, a greater appreciation for life and spiritual growth. We see this in people who have endured war, natural disasters, bereavement, job loss, and economic stress, serious illness, and injuries. This picture is beloved to me. I love this picture because it's my own family. And it's the only picture that we have like this. This right here, this little girl who's 4 years old in this picture, this is my great-grandmother. My great-grandmother, and these are her parents. So this is my great-grandmother, my great-great-grandmother, and my great-great-grandfather. And they were sharecroppers. And I often look at this picture and think about what their experiences of trauma, especially racial trauma, medical trauma, what they were, what it could have been. I can't imagine, because I just don't think that it was very easy to be happy and have joy and be Black during that time. And I often think about what was passed on to my grandmother. You know, she had my grandmother, who I was raised by. So just to put it in perspective, you see how old this picture is. Early 1900s, you see my great-grandmother. And I know that she passed on experiences to my grandmother, who's passed them on to me. And what I have learned to do is, how can I grow from this experience? What is it that we can take from it? Because And then how can I use it to dictate what I want my story to be? Too often for African Americans, the socioeconomic barriers and circumstances that we have dictate what our life will be. And we know this through the ACEs, the ACE, adverse childhood experience. Many of us are familiar. This list of questions that they ask us to determine whether or not these lists of questions determine what our health outcomes will be. It can determine our substance abuse use. And it says, if you've had certain experiences, this is what the outcome will be. I mean, it's very helpful, but I hate the idea that something that happened a while ago can dictate what my life can be. As clinicians, we are learning to empower our patients to make the decision. So knowing the story and then dictating, are you going to allow this story or this experience of historical trauma to dictate how you take care of your body? The answer is no, we don't want that to be the case. And so we use those painful experiences to grow. And African Americans have a host of painful experiences that we can truly grow from. And we as practitioners want to utilize the power of choice and self-determination to help our patients choose a narrative that is best fitting for them, despite the history of trauma. So I am going to end with the video. This is called Michelle's Story. I love it because it highlights what it looks like to be empowered, and how community and relationship play a role. And the last video that I showed with the descendant of the syphilis experiment, it stated that we, the medical professionals, the social workers, we are the messenger. We have the message that we are going to give to our patients and clients that we come across with. And we are the secret weapon is the word that was used. And so we have an ability to empower our patients. And this video gives a beautiful example of that. So I'm gonna go ahead and play it. Empowerment. And when again, I look at my own family, I told you I was raised by my grandmother who has had chronic pain since I've known her. Fibromyalgia, diabetes, directly related to stress, chronic stress and depression. And she also had depression. And being raised by her, I saw her in her strength in so many ways, so many things I saw from my grandmother that I want to have, and a level of resilience that I want when it comes to my own child. But I also saw things that I don't want, and things that I refuse to take with me. I refuse to accept diabetes. I refuse to accept diabetes because I know now I'm empowered to change the way I eat and to change the things that I do. And as a community, I encourage us all to do that, and those working with and collaborating in the community to continue to put those efforts forward to really lessen the disparity. And if you have well, we do have questions. If there are any questions, please put them in the Q&A. Don't put them in the chat. I would love to get your questions. And I mean, that is the end of our presentation. I do have my website is not up right now. So if you do need to contact me, please do so at my email address, info@mattersofourmind.com. Website is not active in this moment. So thank you so much. Thank you. And Julia, you can get to any questions that we may have.
Thanks. So just a quick reminder, we will have a knowledge check question, but we're going to save it until the very end. So we'll be launching that in a few minutes here. But we do go till 12:15 today. So we have some time for Q&A. Okay. So I did see there was a great question earlier that was in the chat. So I'm going to try to scroll back to it. Once again, if you all are able to put your questions in the Q&A, that helps a lot. So, okay, so the question was, I question the structure of anything that has been built on white supremacy and patriarchy. Mm-hmm. How can we restructure healthcare to be more equitable?
So I think that it actually starts with narrative. We have to get our stories out there. You know, Michelle's story, people don't know what the structure, for example, when we look at the Dr. Marion Sims and what happened to the slaves that he experimented on, we don't know her story. We don't know what she experienced. Those stories are not out there. Getting that information from your clients and using it to shape how we structure our services, because oftentimes we have policies and procedures that are just kind of on autopilot that don't factor in those experiences of other people, because the stories aren't out there. A lot of times you just don't know. And so being intentional about getting that information, those stories, and then also consultants, people who can come into your agency and really help you to look at how to restructure things to make it more equitable. I hope that helps them. And then the policy, the way you vote, and I'm not gonna say nothing, I'm just gonna keep it there. I'm gonna say the way you vote impacts policy, and policies impact the way that the treatment and the healthcare that we receive.
Thank you so much. We have one that's just a comment, just you've covered so much for us as a community to do better. And I've seen a lot of comments like that in the chat, just a lot of gratitude for that information today. So thank you so much. I'm not seeing any other content questions at the moment. So if anyone else has questions for our presenter, please be sure to put them in the Q&A. If you're not sure how, you can just navigate on Zoom to the bottom Zoom toolbar where there's a little icon with 2 speech bubbles and it says Q&A. And if you click on that button, you'll be able to type in your question if you have one that you want to ask. And we still have a few minutes left, so I'll give folks a moment if they have any questions they want to think about. I also had seen a question about whether you could have the slides emailed afterwards. So I've been sharing the link to the slide throughout in the chat, but I will also be emailing out that same link again in the evaluation that will go out afterwards. And I also will send out the links to those videos that we watched today as well. So that'll be with that evaluation. There will be some resources in that email. We have a question here. I'm not sure if this is for the presenter or if this is about the OSU series, but someone asked what other trainings do you have coming up? So Ms. Works, do you have any others? I know you don't have any scheduled with our series.
Right, so I do. I do this. This presentation I've been doing most often, but I do another presentation on historical trauma that really looks at African-American behaviors and some of the maladaptive behaviors that have come as survival and how we can work through those. So I do a lot on racial trauma. I also have a presentation that I'm going to be working on that looks at epigenetics. We talked about it earlier, but really understanding how our genetics are impacted by our trauma and DNA. So truthfully, I like to work with organizations. They may have different needs. So there have been organizations that I've worked with who said, hey, we need a diversity equity committee. We need to understand racism better. We need to understand bias training or racial trauma. So I encompass all of those things. I hope that answers your question.
Thank you. And would they be able to find info on your website about any future?
Not on my website, but if you email me, I can get you connected to a newsletter.
Okay, that's right. So the website was the one that was down, so they should email you. Is that right?
Yeah, I should have it up soon, but yes.
Oh, okay. Sorry.
If you want to stay connected to my newsletter, email me and I'll make sure I get you connected.
Perfect. Thank you.
Thank you.
And then someone had asked if you've ever considered creating a support group or anything along those lines for folks who are, committed to this work.
The answer is yes. And I am actively in the process. I enjoy what I do with professionals, but in workshops, but yes, I'm going to give you this. You can follow me on this Instagram site. It is very new, but I will allow you to follow me. It's called Healing for the Culture, and I'll put it in the chat box. I'll send it to Julie, who can put it in the chat box. If you stay there and just follow me, we have some things coming that really looks at the collective healing and how to do the work. So yes, I'm really excited about that, by the way.
Thank you.
Mm-hmm.
And then we also had questions about the email address. So it's that one there, info@mattersofourmind.com is the best one, right? Okay, yes. So that's the email address right there on the slide. Thank you for sending that in the chat as well.
Mm-hmm. I send it to you directly, so if you could post it.
Sure, yeah, do that now, thanks. And the Healing for the Culture was that Instagram you said?
Yes, that's Healing for the Culture _ Instagram. You can go follow that page, and I have some things coming very, very soon.
Okay, Perfect. Thank you. And then someone had asked if you do any longer training sessions on this same topic, like any extended versions.
I don't have an extended version, but usually when I'm working with an organization is, let me kind of know what you want, and I'm able to kind of grasp the presentation towards your needs.
Perfect. Thank you. Okay, well, it looks like we're probably around a good time to launch our knowledge check questions.
Yes.
So if there aren't any more,
I see one more question. I don't know if was already answered or not.
I think that's the one we just took. So
okay, perfect.
Yeah, so we'll go ahead and launch our knowledge check question. And if anyone else has questions coming up, let us know.
Okay.
So Ms. Works, if you wouldn't mind advancing to the very last
yep.
slide.
I always forget that I have to do that part.
Yeah, sorry about that.
No worries. All right, let's complete our knowledge question.
Okay, so we've just gone ahead and launched the knowledge check question, which is now also the same exact question should show up as a poll if you're joining by computer. So the knowledge check question today states, choose the best answer to describe effective ways to help African Americans build trust in their healthcare system. Is it A, share your political views to better connect with the patient? B, establish a healthy relationship with the patient to build trust and decrease fear? Or C, establish a healthy relationship with the patient, utilize fictive kin, and empower patients through the use of narrative? So I will read that one more time for anyone who may be joining by phone. So the knowledge check question states, choose the best answer to describe effective ways to help African Americans build trust in their healthcare system. A, share your political views to better connect with the patient. B, establish a healthy relationship with the patient to build trust and decrease fear. Or C, establish a healthy relationship with the patient, utilize fictive kin, and empower patients through the use of narrative. So I'll leave the question up for those who have not had a chance to respond yet. If you are having any trouble answering it via poll, or if you're joining us by phone, you're welcome to email us your response. That email address, once again, is ohiopc@osu.edu. One more time, that email address is ohiopc@osu.edu. So that is the best place. If you're not able to answer the poll directly, you can, if you're joining by computer, you can either send it to us via a private chat, or you can send your answer via email, again, to ohiopc@osu.edu. And at this moment, I just want to take a second to just thank you so much to Ms. Works for this wonderful session today. It's so important and timely, and we just really appreciate all your hard work and time.
Thank you so much, Julie. Thank you, Julie. I appreciate it.
Really, really appreciate your time today. And this, I've seen so many positive comments as well. So
thank you.
Such an important topic. So thank you very much. And I will give everyone another moment to finish responding.
Do we have another question? I'm sorry.
Someone just wanted to change their answer. So
okay,
I will make sure that is noted. And thank you all so much for your time today. We will have some more sessions in our series coming up for September. So I encourage you to feel free to take a look at those at ohiopc.org. And as a quick reminder, in order to receive a certificate today, you do need to have attended the full session. We are unfortunately unable to award partial credit, so we do need a full attendance record. So you need to have attended the full session, answered our knowledge check question that's currently listed. And if you haven't had a chance to answer it, please be sure to email us your response at ohiopc@osu.edu. And then the final step is that you will receive an evaluation to your email within 1 business day. If you do not receive it within 1 business day, so by the end of tomorrow, please be sure to check your junk or spam folder first, because they often end up in there. And if you do not have one, please email us at that same ohiopc@osu.edu address, and we will make sure you get the link. And then if you've completed all of those requirements, you can expect a certificate via email within 30 days of today's date. So I'm going to go ahead and get ready to end our session here. Again, if you've not answered the knowledge check, please do email us your response, and you can send us any questions that you have as well. And thank you once again, Ms. Works. Really appreciate your session today. And then thank you to all of you for joining us, and we appreciate your time and hope you all have a wonderful day. So I'm going to go ahead and close the session. Thank you all again, and take care.
Thank you.